Hello, everyone. We are Glucase. We are from Case Western Reserve, and today we are taking precision medicine for diabetes care to the next level. My name is Jacqueline. I'm a clinical translational science PhD student.
My name is Dr. Odoye. I'm a fourth year MD PhD student here at Case.
My name is David Salvaraj. I'm a clinical and translational science PhD student and a data analyst as well.
Hi, I'm Jacob James Rich. I'm a PhD student in epidemiology and biostatistics, and I specialize in mathematics.
My name is Chris. I'm a senior medical student at Case Western Reserve and a research fellow at the Coli Institute this year.
Our faculty advisor is Dr. Scott Williams. He's a geneticist and epidemiologist, and we very much thank him for his time. Diabetes is the inability to regulate your blood sugar levels. This is a chronic and lifelong condition with the gold standard of measurement being your HbA1c level, which is your average blood sugar levels within the last 2 to 3 months. But the fact is, no one is safe from diabetes. Since 2004, the prevalence of diabetes has drastically increased. As diabetes is a chronic and lifelong condition, it is here to stay. Its longevity and comorbidities will continue to invade our homes and communities. With 37 million Americans affected, this is a substantial portion of our community and a true crisis in our country. Diabetes costs $327 billion annually, which accounts for 1 out of every 4 healthcare dollars being spent on diabetes care. This equates to 800 million in diabetic retinopathy, 15 billion in diabetic nephropathy, 34 to 9,700 more for heart disease in patients with diabetes, and 15 billion in foot disease. With appropriate preventative implementations, however, we can actually lower the diabetes complications for kidney disease up to 37%, blood sugar complications by 40%, blood pressure complications by 50%, cardiovascular complications by up to 50%, visual complications by 90%, and foot amputations by 85%. This would save an estimated amount of $76 billion. But the problem is, with so many Americans affected with diabetes, how do we best utilize our resources? Wouldn't it be nice if we could provide faster preventative implementations for diabetes complications? Diabetes also disproportionately affects our minority communities. Within the United States, the white population makes up about 63%. However, when we look at the diabetes incidence or the amount of new diabetes cases arising, we find that the indigenous and the Black populations are disproportionately affected. When we look at how much people are spending on diabetes care, we found that Black Americans are spending the most. So to summarize, Black Americans have the second highest rate of type 2 diabetes diagnosis and the highest diabetes-related expenses. Next, David will discuss how we are going to address this problem.
Thank you, Jacqueline. In the past, diabetes was thought of as one disease, and because of that, many people lost their lives. Currently, diabetes is thought of as 2 types, type 1, which is autoimmune diabetes, and type 2, which is insulin-resistant diabetes. Recent work, however, has shown that there are more than just 2 subtypes, and we hope to expand upon the subtypes and validate novel subtypes that exist currently in the literature. So why are subtypes important? Comorbidities and risk factors vary by subtype. Different subtypes are associated with different diabetes-related risks. And for example, one proposed subtype in the literature was found to be associated with higher levels of diabetic retinopathy. And one was found to be linked to higher odds of chronic kidney disease. So you may ask how our subtyping will help with the process of recognizing diabetes. So for instance, if you go to a visit and your doctor pulls up your EHR record, automatically your information, including your genetic information, which might be in your EHR, your sociodemographics and lab values and measurements will be synthesized. And on the left-hand navigation, potentially you'll see a little pop-up, which will tell you your diabetes subtype. And for instance, if you have a high risk for a subtype that's associated with diabetic retinopathy, your physician might be prompted to refer you to an annual eye exam as a result of that. So where do we come in? We're Glucase, and we're going to redefine diabetes and their subtypes for the purpose of precision medicine and targeting interventions to these subtypes. So how are we going to do that? We're going to use the All of Us research program and its data. So the All of Us data set and research program is a very ambitious project, which hopes to enroll 1 million participants. And the data set is going to be enriched with minorities, specifically Black and Hispanics. And currently they've enrolled about 400,000 participants, and they already have about 50,000 that have diabetes diagnosis and about 100,000 that have genetic data. And at Case Western, we're very fortunate because we all have access to the controlled tier of data, which has the genetic information on an individual level. So we're able to harness that data. So how are we going to do our clustering? We're going to start using a very basic k-means clustering algorithm, and hopefully we're going to be able to find or validate novel subtypes for type 2 diabetes. And then we'll be able to label those subtypes based on the characteristics in each subtypes and try to associate those subtypes to patient outcomes. Next, once we have our clusters or labels, we're going to try to predict our clusters. So we're going to use Keras, which is a framework for supervised learning. In this case, we're going to use a sequential neural network model, and we're going to use all of the features we've talked about from the All of Us data set, and Razak is going to expand upon those. We're going to take those and create an input tensor with our output labels that we determined from our clusters. And we're going to use this to predict what subtype people would fall into based on their data. Once we can do that, we can link the predictions to treatment plans. And now Razak is going to talk a little bit about the individual data elements from all of us. Now we're going to incorporate them into our model.
Thank you. Genomic, clinical, and socio-demographic data are all required to make accurate type 2 diabetes diagnoses. But to date, few studies make use of even two of these data elements, and no single tool utilizes all three. The few studies that do incorporate socio-demographic and clinical data have detected subtypes of type 2 diabetes. That said, these studies produce inconsistent clusters and lack the overall accuracy and precision to move these findings into the clinic. Glucase is the first tool of its kind to incorporate genetic information and combine it with both clinical and socio-demographic data in type 2 diabetes subtyping. This sets Glucase apart from other strategies as we utilize one's own unique genetic structure to refine our clustering process, taking precision medicine to the next level. Our goal for Glucase can be divided into two phases. In the short term, we will publish Glucase on the MDCalc website, a widely used medical repository for our tool. This requires the publication and will make our risk calculator available to clinicians for immediate use. In the long term, we're engineering Glucase for implementation into hospitals' electronic health record. We appreciate that this is a long process, but this goal for our decision support tool will rapidly classify patient risk, save clinicians time, and guide our personalized patient treatments. Creating an interface for diabetes complication risk, like the one seen on the right, that is easy to use, interpretable, and accessible both for clinicians and for patients, especially those that are underserved, is vital to our project. This will allow Glucase to reach its full potential in the clinic in addressing and ultimately reducing type 2 diabetes health disparities during patient visits in real time. Glucase is a novel tool that represents a significant improvement to current strategies and brings innovation to medicine in three distinct ways. First, implementation is key. This tool is designed to be accessible. Second, disparities exist, and only by incorporating diversity into Glucase through the All of Us database can we address these disparities. And third, we're using machine learning to detect and refine patterns clinicians and researchers have so far missed. And here is our project timeline. We've broken down each of our anticipated steps and plan to have the first part of our short-term goal achieved by May 5th, 2023. We have shown that health disparities in type 2 diabetes fall along racial and ethnic categorizations, and the current tools are insufficient to deal with them. Early intervention with personalized treatments saves patients time, money, and years of quality life. Using an evidence-based approach, Glucase is a vital tool that supports clinician decision-making in type 2 diabetes treatment. Glucase incorporates the diversity of those most affected by type 2 diabetes so that clinicians can intervene and partner with patients to reduce health disparities, especially in marginalized communities. Thank you. And with that, we're ready for questions.
Thank you so much, everyone.
Judges, please feel free to come on camera and ask your questions.
Yeah, I can go first. Maybe I'm a little bit unclear of what the problem is and what the solution is. So what did you say that the problem is, that you cannot get the therapeutic or the diagnosis to people fast? And in your case, the solution will be that, I'm actually confused about what the solution will be. Are you creating new subtypes or clustering groups or a risk score for diabetes? And then maybe the third and final question, let's say there's a risk score of 4. Then what do you do? What's the difference? What's the intervention going to change before your glucose program was in place?
Yeah, thank you very much for this question. So essentially, the problem we've identified is that classically, or at least for the past several decades, diabetes has been classified generally as type 1 or type 2 diabetes. And recent work by several groups has shown that there might actually be several subtypes of type 2 diabetes, each of which is associated with its own risk factors and possibly their own higher risks of different complications of type 2 diabetes. And so we're targeting this gap in the knowledge to see if we can, first of all, validate previously suggested novel subtypes, but also see if we can establish new subtypes that perhaps weren't identified in the previous literature, as we'd be the only group that's going to incorporate genomic data into establishing these subtypes. Once we establish subtypes, we then try to see if there's any, for example, higher risk of complications of specific diabetic complications within a certain subtype. If we establish one subtype has a higher risk for diabetic retinopathy, for example, you'd be able to guide clinicians to make sure that they're following up on their patients and getting them annual eye exams. If, for example, another subtype has a higher risk for diabetic neuropathy, you'd be more cognizant of performing your annual exam with a monofilament fiber for their feet. So I think that's the kind of gap we're trying to address.
And just to add on to that, another part of this is right now there are 37 million Americans that are affected with diabetes, which makes targeting all 37 million for every single comorbidity practically impossible. We also have to recognize that, different racial groups are going to need different implementations because they have different cultural elements. So how we can best reach that community and make effective targets. So with our subtyping, if we can actually break this down and have a calculator basically warn a physician, hey, your patient's at high risk for chronic kidney disease, well, then we can actually better target that group. And instead of targeting 37 million, perhaps we can really cut that down and therefore help our patients more.
Yeah, I'll share a comment and then a question. I think the comment is, a couple comments are that I applaud the use of the All of Us research data set. I think that is the direction that a lot of us need to move in to get a diverse data set. On your slide where you talked about the different types of risk factors, you actually had race and ethnicity as one of the demographic factors. And there's been a lot of recent, careful look into whether and when we should be including race ethnicity in our models. I think the challenge I have in thinking about the risk score here is that the American Academy of Ophthalmology already recommends an annual eye exam for everyone with diabetes or prediabetes. The foot exam is already recommended for everyone with diabetes. And so the fact that not everyone's receiving it, may not have anything to do with risk, may actually have to do with like barriers to access. And just knowing that someone's high risk may not necessarily be enough to fix that health inequity that I think is primarily, in my experience, related to access issues. So those are just some reflections on, the solution and some of the challenges with the problem. The question I guess I'll ask is, this is a great idea. How do you get genetic data into MD Calc?
Yeah, so that's also a really good question. It's possible that it won't be as feasible to incorporate genetic data into MD Calc. So what we would aim to do is perhaps do a tiered approach with our model. Perhaps on MD Calc, we can publish an abridged version of the model Whereas for later down the line, when we're incorporating it into electronic health records, where you would have genomic data available within the patient's EMR, that could be something that's automatically calculated for the provider and not data that they have to input.
Thank you.
Sure.
Ravi, I think you're muted. I don't know if you're.
Sorry, I have a follow-up question to Garndeep's question. Thanks, Garndeep. So how do you plan on actually taking this data and turning it into actionable use cases? So I can risk stratify them, I can subtype them. How do you then turn that information into putting them on the right pathway? Because you're now going to have to re-educate a large proportion of physicians on what the right pathways for screening surveillance protocols are across an entire diabetic population that's managed through 4 different specialties, really, at the end of the day. So how do you plan on taking it to the actionable part of after you risk stratify them? And then the second question I have is, have you guys considered partnering with payers? Because this may actually be at least the 2 metrics that we're looking at, top right and the bottom, and maybe even some of the genetic factors that payers may have an ability to access some of this data, subtype them, and then put them on clinical care pathways that payers themselves are already driving.
Yeah, so in terms of integrating it into the EHR, so most of the hospitals in the Cleveland area at least are Epic shops. So in Epic, there's a mechanism called care gaps and best practice advisories. And we would try to integrate our decision support tool into those mechanisms. So they would get a left-hand notification saying that the patient is a particular subtype. And then from that, it would give them an option to order certain labs or procedures or make external referrals. So this could be done by a physician in coordination with their nurse staff and MAs too. So it potentially would take some burden off the physician too, because other providers that are coordinating the care of this patient could also see these cues. And then, do you want to answer the second part?
Yeah, regarding the working with payers, we hadn't previously considered that, but that's a really great suggestion. We appreciate that. So we'll definitely look into that.
Actually, one thing to say about that too is that Medicaid is a big payer in our state, and we could work with Ohio Department of Medicaid to create a new code, because then physicians would be incentivized by the payments they would receive for these types of procedures too, and counseling they give their patients. So I think a big part of that is starting with the Ohio Department of Medicaid, because they're one of the largest payers. And I think it would be easier to go work with them.
And to add on to a previous comment, this is a complicated problem to tackle and to really address. And approaching it from as many different perspectives as possible and incorporating providers, payers, factoring in access to care are all vital steps in getting BlueCase to be functional and reduce and address these disparities. So we really appreciate that comment, because it's another perspective to attempt to tackle this disparity.
Yes. And I think the ultimate challenge for getting payers to actually address, to want this to be implemented, is for the providers to actually be providing it in the first place. Once they notice that the providers themselves are saving money, it's going to be very easy for the payers to want to be implemented. So I think the price saving mechanism actually starts at the provider level.
And I think in Cleveland, we're fortunate that a lot of hospitals take on risk-based models of capitation, where they manage their entire patient's book and try to save costs in that sense. So I think we're in a unique environment to roll out these types of initiatives that focus on quality of care rather than just quantity.
But, if I can ask one question, the data quality and the level of granularity, just the intersectionality between Black and Latinos, have you seen enough data, like within the data set, that you feel like you have the quality that you need, just given the pathways and the and essentially the premise here is that you're going to have different treatment plans, right, depending on the variables here?
So we might find that self-reported race might not be a significant predictor. So we might decide to not include that in the model, or if we're using the sequential neural network model, it might be de-emphasizing the weights in the model too. So it might turn out that genetic information or some other measurement is more significant in prediction of subtype. So we haven't gotten into that level of the analysis yet, but yeah, that's a fair point. Self-reported race might not be a good metric for subtyping. Is that what you're getting at, or?
Yes. Mhm.
As an add-on to that, as we consider using race and ethnicity, because we can factor in genomics, we can look at ancestry, like global and local ancestry throughout the genome. And if race or ethnicity, self-reported race and ethnicity is not as informative as we anticipate or as we expect, we can use other methods to factor in that diversity and factor in those population specific differences.